Good morning, everyone. My name is Nikita Israni. I am a junior cardiac physiotherapist working at UNMICRC Institute of Cardiology since 9 years. And today, under this continuous physiotherapy education, my topic is techniques to improve lung volume. Content of the topic is lung volumes and its types, reasons for loss of lung volumes, loss of lung volume and significant problem related to it, and physiotherapy techniques to improve lung volume, which includes different body positions and its physiological effects, different breathing exercises and its usage, mechanical aids to improve lung volume. So first of all, what is lung volume? So lung volumes are also known as the respiratory volumes. It refers to the volume of gas in the lungs at a given time during the respiratory cycle. There are main 4 types of lung volumes, which are tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. These volumes vary by age, gender, and height of a person. Normal lung volume of a healthy male is 6 liters. Here, this is a spirogram which shows the relationship between the different lung volumes and capacities, illustrating the relationship between them. Here, there are 4 respiratory volumes, which are inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. And the inspiratory capacity, which is the combination of the inspiratory reserve volume and the tidal volume. Functional residual capacity is the combination of the expiratory reserve volume and the residual volume. And the vital capacity is the combination of the inspiratory reserve volume, tidal volume, and the expiratory reserve volume. And then lastly, total lung capacity, which is the combination of the vital capacity and the residual volume. So, reasons for decrease in the lung volumes, it could be either intrinsic lung conditions, extrinsic factors, or others. Intrinsic lung conditions includes the intrinsic lung disease, pulmonary fibrosis, lung infections, atelectasis, consolidation, and the pleural effusion. Extrinsic factors include neuromuscular disorders, obesity, rape injury, and the skeletal deformity. And others involve aging and the smoking. So, loss of lung volume when it is a significant problem, when it causes the decrease in the surface area for gaseous exchange, decrease in the lung compliance, and when there is an increase in the work of breathing. So, here are some physiotherapy techniques to increase lung volume, which are controlled mobilization, positioning, breathing exercises, and mechanical aids. So first, controlled mobilization. It is the most useful technique to improve lung volume. It is first-line treatment for patients who can get out of bed. Controlled mobilization include upright postures, which encourages basal distribution of air with natural deep breathing. So controlled mobilization includes relaxed standing, forward lean against wall, transferring the patient from bed to chair, and the sideline in bed. Here, the level of activity is controlled, so patient becomes slightly breathless. There should be some safety check we should do before mobilizing the patient. When we mobilize the patient in the bed, we should check for the bed lock. When we mobilize the patient from bed to wheelchair, we should check for the propel lock of wheelchair. And when we mobilize the patient from bed to wheelchair, we should check for the lines and tubes for the security. And when we mobilize the patient from the bed, we should encourage the gradual transition of one position to another to avoid the effects of orthostatic hypotension. And we should also check for any signs of breathlessness and desaturation during the mobilization of patient. Here is the schematic diagram of the gradual progression of patient using the stepwise approach in which patient is in supine lying position. From transferring the patient from supine to the sitting position, we should always turn the patient into the side lying position. From the side lying position, we should turn the patient into the sitting position. From the sitting position, we should always ask the patient to come at the edge of the bed. After sitting at the edge of the bed, we should ask the patient to do some standing, and after standing, we should ask patient to do some marching on the spot, and after marching on the spot, we should transfer the patient to the chair, and after transferring the patient to the chair, then we would progress towards walking. Here is the diagram of progressing patient from supine lying to sitting position. In first, the patient is in total supine lying position. The second one is the recumbent position when the patient is in 30-degree head end elevation, and in the fourth one, the patient is in the 45-degree head end elevation, which is propped up position, then transferring the patient into the 90-degree head end elevation, which is sitting position. So after that, positioning. So positioning is the method of placing a patient in proper postures to maintain alignment, prevent deformities, improve circulation and respiration. It is a non-invasive physiotherapy intervention that can augment arterial oxygenation and postpone or reduce the need for mechanical ventilatory support. There are some physiological effects of positioning. So, it improves the lung volume, it reduces the work of breathing, it optimizes the oxygen transport by improving ventilation perfusion mismatch, it enhances the mucociliary clearance, it restores the ventilation of dependent lung regions, it improves arterial oxygen saturation, it improves gaseous exchange. So here is the graphical presentation of FRC in different positions. In x-axis, there are some different positions including head down to the upright and sitting position, and in the y-axis there is a functional residual capacity. In the head down position, there is a decrease in the FRC, and when moving from the head down position to the upright position, there is a gradual increase in the FRC, and the maximum FRC is achieved in the upright position. So here is another diagram of the FRC in different position and the closing capacity related to age. In x-axis, the age is shown, and in the y-axis, the lung volumes. With the age, closing capacity increases, and in the supine lying position, FRC is reduced compared to the FRC in the upright position. Here, the image shows the effect of body position on the peripheral blood flow. So, when the patient is kept in the head down position or supine lying position, the peripheral blood flow is reduced. But when patient is kept in the upright position, the good peripheral blood flow is given. So, the second image shows the effect of body position on the drainage from the pelvis of the kidney. When the patient is kept in the erect position, there is a good drainage from the kidney occurs, and there is a reduced stagnant area. And when the patient is kept in the supine lying position, there is increased stagnant area, and the drainage from the kidney is not so good. There are some different body positions, including supine lying position, side lying position, prone lying position, head down or the Trendelenburg position, and the upright position. So first of all, supine lying position. Supine lying is easily adopted but unhelpful for lung volumes because diaphragm is inefficient and less coordinated with chest wall mechanics. Here, there is a cephalate position of the diaphragm. The supine lying position increases the area of dependent lung volume. It increases the closure of airway, and it decreases the FRC, and there is a decrease in the vital capacity. Here is the graphical presentation of body position on the distribution of mucus. So, in the upright position, the mucus is well distributed, and in the supine lying position, the mucus is stick in the dependent area of the bronchial wall. Here, the second image shows the collection of secretion in different positions. So, in the erect position, the mucus or the secretion is well distributed as compared to the supine lying position. In the supine lying position, the mucus is adherent to the dependent area or it is not well distributed. Then second is the side lying position. Compared to supine lying, side lying is more physiological and thus have more therapeutic benefits. Side lying increases the FRC compared to supine. It increases the lung compliance. It decreases the work of breathing. It enhances the efficiency of oxygen transport and decreases the use of supplemental oxygen. There is a optimal ventilation perfusion matching occurs in upper one-third of each lung. Arterial blood gases improved with the affected lung up and the good lung down. Here it is the image of the patient in the side lying position. When there is a unilateral lung disease, the image shows the effect of positioning in a patient with the pneumonia. When patient is having pneumonia and when we kept the pneumonic lung down, there is increased perfusion of the poorly ventilated region, but there is increased ventilation and perfusion mismatch, and which ultimately could lead to the worsen in the hypoxemia. And when we put the pneumonic lung up, there is an increased perfusion of poorly ventilated region and there is a decreased ventilation perfusion mismatch and improve the hypoxemia. So here is the bad lung up rule. In the unilateral lung disease such as pneumonia, pleural effusion, atelectasis, etc., which involving the one side of the lung, the lateral decubitus position with the involved side always up with their good lung down improves the arterial oxygenation because of the ventilation and perfusion matching. Here in the schematic diagram, consolidated lung is in the non-dependent position, whereas the normal lung is in the dependent position. Then the head down position or the Trendelenburg position. Head down position augments oxygen transport in patient by improving pulmonary mechanics. In this position, diaphragm is positioned more normally in higher position, so it is more mechanically efficient position. Here, there is a decrease in the dyspnea. It decreases the accessory muscle use. It is helpful for reduced minute ventilation and it decreases the upper chest breathing pattern. Prone position, it is considerably physiological position. It improves arterial oxygenation. It decreases the work of breathing. It increases the tidal volume and improves lung compliance. There should be some precautions we should keep in mind during placing the patient into the prone position. So, patient should be monitored continuously during prone position, whereas in semi-prone can provide more physiological benefits of a full prone and minimize the risk. Semi-prone position is more conservative, safe and comfortable position. So here is the graphical presentation of physiological effects of prone position. So first of all, effects on the lungs where there is a regional ventilation in the dependent lung increases and the matching of the ventilation and perfusion is also occurs. It decreases the airway closure into the dorsal lung regions. It enhances the secretion removal. It increases the functional residual capacity and it is helpful to reduce the diaphragm when there is a reduced in the diaphragm movements. The physiological effects on heart, it improves the cardiac output, it increases the systemic venous return, it increases the right ventricular preload and it decreases the right ventricular afterload. The effect on abdomen, the pressure on the dorsal lung is decreased and the intra-abdominal pressure increases. Upright position. So, upright position increases the FRC. It decreases the risk of airway closure. It optimizes the diaphragm mechanics. It decreases the compression of the heart. It increases the alveolar recruitment. Then breathing exercises. So, what is breathing exercise? Breathing exercise is fundamental intervention for the prevention and management of impairment related to acute and chronic pulmonary disorders. So, some goals of breathing exercises. So, it improves the ventilation, it promotes relaxation and relieves stress, it prevents post-operative pulmonary complications, it increases the effectiveness of cough and promote airway clearance, it improves chest mobility, it decreases the work of breathing, it improves the overall functional capacity of a patient. Here, there are some types of breathing exercises which are diaphragmatic breathing, segmental breathing, pursed lip breathing, and the glossopharyngeal breathing. So, first of all, diaphragmatic breathing. So, diaphragm is the primary muscle of inspiration. Diaphragm controls the breathing at involuntary level in the patient with primary or secondary pulmonary dysfunction. In this, patients should be taught how to control breathing by optimal use of diaphragm and decrease the use of accessory muscles. So, here is a procedure for the diaphragmatic breathing, in which first of all we should prepare the patient in relaxed and comfortable position in which gravity assists the diaphragm, such as semi-fowler position. Therapist should place her hands over the rectus abdominis just below the anterior costal margin and ask the patient to breathe slowly, relaxed, deeply via nose by keeping the shoulders relaxed and upper chest quiet, allowing the abdominal content to rise. Then ask the patient to slowly let all the air out using controlled expiration through the mouth. Here is the image of diaphragmatic breathing, in which when patient inhales, diaphragm contracts and moves downward, belly expands, the air goes inside the lung, and when patient exhales, there is a contraction of the abdominals and the intercostal muscles that pushes the diaphragm upward and the air in the lung goes outside. Then the segmental breathing. It is performed on the segment of lung or a section of chest wall that needs increased ventilation. Hypoventilation occurs in certain area of the lungs because of the chest wall fibrosis, pain after surgery, trauma to the chest wall. Therefore, it will be important to emphasize expansion of such areas of the lungs. First of all, lateral basal expansion. In this, patient should be in sitting or in a hook-lying position. Place the hands on the affected area of the patient. Ask the patient to breathe out and feel the ribcage move downward and inward. As the patient breathes out, place firm downward pressure into the ribs with the palm and check for the next breath with greater depth. Here, the image shows the lateral costal expansion in sitting and the lateral costal expansion in supine-lying position. The therapist places her hand on the lateral costal margin of the patient's rib cage. Then the posterior basal expansion. Have the patient sit and lean forward on pillow and slightly bending at hip. Therapist should place her hands over the posterior aspect of the lower lip and do the same. Check for the next inspiration with the greater depth. Here, the therapist is placed her hands on the posterior basal aspect of the patient's rib cage. Then the glossopharyngeal breathing. So, glossopharyngeal breathing is used in patients with a decreased inspiratory capacity and severe weakness of the inspiratory muscles. It is used for ventilatory dependent patients due to absent or decreased function of diaphragm. Glossopharyngeal breathing with inspiratory action of neck muscles can reduce the ventilatory dependence and can be used as an emergency procedure when there is a malfunctioning of ventilator. So, procedure of the glossopharyngeal breathing. Here, patient is asked to take several gulps of air, around 6 to 10, by closing the mouth, and the tongue pushes the air back and the air is trapped in the pharynx. Then air in the pharynx forced into the lung when the glottis remains open. This increases the depth of inspiration and improves the patient's inspiratory as well as vital capacity. The fourth one is pursed lip breathing. This technique involves slightly pursing of the lips together during controlled exhalation. It can be used in patients of COPD to deal with episodes of dyspnea. It keeps the airway open for a longer period of time, and prolonged exhalation helps to decrease the respiratory rate. The image shows the pursed lip breathing, which includes three stages. First one, in which ask the patient to inhale slowly through the nose. The second one, ask the patient to purse lip as he would whistle. And in the third phase, ask the patient to exhale slowly while keeping the lips pursed. Then the mechanical aids. So, what is mechanical aids? Mechanical aids are devices that assist or augment lung inflation by positive pressure or volume assistance to increase the lung volume and prevent alveolar collapse. It includes incentive spirometer, CPAP, BiPAP, PEEP, IPPV, mechanical ventilation, and high-flow nasal cannula or the HFNC. First of all, incentive spirometer. Incentive spirometer is a mechanical device that used to encourage slow, deep inspiration for increasing the lung volume and prevention of lung atelectasis. It provides visual feedback that encourages patient to sustain maximum inspiration, thereby it improves the lung volume. Here are some benefits with the use of incentive spirometer. So, it prevents the atelectasis, it improves the lung volume, it encourages the deep breathing, and it reduces the risk of post-operative pulmonary complications. There are main two types of the incentive spirometers. First one is flow-oriented spirometer, which is standard and used maximally, and the volume-oriented spirometer. So, here in the image, first one is the flow-oriented spirometer, which is standard and it is used maximally, and the second one is the volume-oriented spirometer, which is less commonly used. Non-invasive ventilation or the NIV modes. It includes the nasal CPAP, nasal continuous positive airway pressure. Nasal CPAP is a non-invasive ventilation mode in which a constant positive pressure is delivered throughout the entire respiratory cycle, both inspiration and through the expiration via nasal bronchs or mask. It does not provide breaths but maintains the airway open and supports spontaneous breathing. So here is the mechanism of the NIV modes. So it provides the continuous pressures which keeps the alveoli open. It improves the functional residual capacity or the FRC. It prevents the alveolar collapse and it reduces the work of breathing by decreasing airway resistance. Pious flow, that is 2 liter per kg per minute, and it can be increased up to safe maximum. For the very small neonates less than 1 kg, it should be kept at 4 to 5 liter per minute. For children with the weight of 1 to 2 kg, it should be at 5 to 6 liter per minute. When the child is of 2 to 5 kg, it should be at 6 to 7 liter per minute. And when the child is more than 5 kg, it should be kept at 7 to 8 liter per minute, and we can go up to 10 liter per minute if the leaks are high. So here is the image showing the different size of the OptiFlow Junior Nasal Cannula. In the first one, that is red color, and it is used for the premature neonates, in which it delivers the 8 liter per minute flow. And the yellow one, which is used for the neonates, it also delivers the 8 liter per minute flow. And the purple one, which is delivers the 20 liter per minute flow, and it is used for the infant. And for the green one, which delivers a maximum flow of 25 liter per minute, and it is used in the pediatric patients. Then bilevel positive airway pressure, or the BiPAP, it gives a higher pressure during inspiration, IPAP, and lower pressure during expiration. Then the non-invasive pressure support, NIVPS, that supports the patient's own breaths with set inspiratory pressure. Then the non-invasive spontaneous timed NIVST, which provides the timed backup breaths if the patient does not initiating breathing. Then the CPAP, that is continuous positive airway pressure. So it increases the FRC by maintaining the positive airway pressure. Then the PEEP, positive end expiratory pressure, it prevents the end expiratory alveolar collapse. IPPB, that is intermittent positive pressure breathing, it provides the assisted deep breaths. Then the mechanical ventilation. So the mechanical ventilation provides the full or the partial control of ventilation. And then the high flow nasal cannula, or the HFNC, it provides the low level of PEEP. First one is CPAP, continuous positive airway pressure. So it is a non-invasive positive pressure ventilation that delivers a constant and steady level of positive air pressure through a mask during breathing. It is the best strategy to buy time for medical therapy to treat rapidly reversible causes of respiratory failure. There are some benefits with the use of CPAP. So, CPAP keeps the alveoli and airway open. It prevents the airway collapse, especially during sleep. It improves the oxygenation and reduces the work of breathing. The common clinical uses of CPAP. So, it is used in the hypoxemic respiratory failure. It is used for the prevention of the post-operative atelectasis. It is also used for the obstructive sleep apnea and the cardiogenic pulmonary edema. Then BiPAP, bilevel positive airway pressure. So BiPAP delivers higher pressure during inspiration, that is IPAP, and lower pressure during expiration, that is EPAP, making exhalation more comfortable. Here are some benefits with the use of BiPAP. So BiPAP is more comfortable than CPAP for some users. It provides adequate oxygenation and help to clear carbon dioxide. It allows for spontaneous breathing. Then IPPB, or intermittent positive pressure breathing. So IPPB is a non-invasive ventilatory technique commonly used for lung expansion and to reduce the work of breathing. It is usually delivered via mask. There are some physiological effects of IPPB, which are: it increases the tidal volume, it decreases the work of breathing, it improves the alveolar ventilation, it assists in the secretion mobilization, and it helps to decrease the atelectasis. Here in the image, the first one is the image of the HFNC machine, and the second one is the image of the nasal cannula, which is used in the younger pediatric patient and in the adult patient. Then physiological benefits of HFNC. So it is a high flow oxygen delivery system. Here flow meets or exceeds the patient's inspiratory demand. It ensures a stable FiO2, that is fraction of inspired oxygenation. It decreases the dead space and it causes the dead space washout. So it clears the exhaled CO2 from the upper area and improves ventilation efficiency. It provides the low level of positive pressure and it provides a mild CPAP-like effect, that is 2 to 6 centimeter of H2O depending on the flow. It provides heated and humidified gas and prevents the airway dryness and mucosal damage. It improves the secretion clearance and comfort. Here, the image shows the HFNC machine and the humidification system. In first one, the sterile water pint, which is continuously attached to the HFNC machine and it provides the humidification. And the second one, there is a basic parameter of the HFNC, in which first one in the orange color, which shows the temperature of the humidifier. The second one is the flow that is delivered to the patient, and the third one, which is in the green color, which shows the fraction of inspired oxygen. Here are some references. Thank you.